Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. I'm Rawan Abu Alnasr, clinical pharmacy resident from King Fahad Medical City, Riyadh. Today, inshallah, I'm going to present big asparaginase associated toxicity in children with acute lymphocytic leukemia. Okay. As we all know that leukemia is the most common type of cancer affecting children worldwide, representing approximately 35% among Saudi children, and ALL considered the most common type of malignancy of all childhood leukemia. And as we see in the graph here, the addition of asparaginase to chemotherapy actually has significantly improved the survival rate and the cure rate in pediatric ALL patients, with survival rate reaching up to 90%. But unfortunately, big asparaginase causes significant toxicities in up to 25% of patients. Those toxicities may lead to discontinuation of biovital component of a potential curable disease and eventually lead to decrease the survival rate by 15 to 20%. The most common type of toxicity associated with big asparaginase including hypersensitivity, anaphylaxis, hepatotoxicity, hyperglycemia, pancreatitis, and coagulopathies. So what about the risk factors that are associated with increasing big asparaginase toxicity, starting with the route of administration? Actually, there was a debate whether IV administration causes significant hypersensitivity reactions than IM, as IV rapidly rise the ammonia level and cause allergic-like reactions. But recent studies demonstrate that IV asparaginase can be given safely without causing significant toxicity. And the COG group modified many of pediatric ALL protocols to reflect this. And now IV administration is the preferred route, as rapid anaphylactic reaction occur within an hour. So you can manage the patient while he is in the hospital, where this is impossible with IM injection, as the reaction take 4 to 6 hours to occur after the patient sent to the home. Additionally, IV administration allows the use of high continuous dose schedule without the pain and the anxiety that associated with multiple IM injections. What about the dose? Actually, in adult ALL patient, big aspar dose is capped to 3,750, as higher doses associated with higher toxicity, while in pediatric patient, big aspar is not capped. However, recent study showed that doses 3,750 and higher in pediatric ALL patients associated with higher rate of VTE, pancreatitis, and hypoglycemia. So, up to our knowledge, there is no published data reported from Saudi Arabia describing the characteristic of big asparaginase associated toxicity in ALL patients and their associated risk factors. So we want to describe the prevalence of most common big asparaginase toxicity in pediatric ALL patients. Moreover, we want to determine the differences in big asparaginase toxicity in regard to the dose, and to quantify the rate of toxicity in patients who receive IV versus IM. Our study design, it's a retrospective single-center cross-sectional study. The hospital electronic health record was used to complete a chart review between January 2020 to March 2023 at King Fahad Medical City Children's Cancer Center. We include all pediatric ALL patients 14 years and younger who received big aspar, and we excluded any patient older than 14 or any patient received other asparaginase formulation. Here is the big asparaginase toxicity grading sheet that used in our study. It was based on the common terminology criteria for adverse event. Actually, the grading was verified by 2 independent reviewers. The statistical analysis actually done by our biostatistician in the institution. So let's move the result. A total of 191 ALL pediatric patients were identified during the period of 3 years. Majority were male, and the most observed diagnoses were standard risk ALL, followed by high risk ALL and T-cell ALL. And as expected, majority of our patients, 91% received doses less than 3,750. So what about the prevalence of toxicity? Actually, we found the prevalence of big asparaginase toxicity in the period of 3 years, reaching up 41% in our patient population, with anaphylaxis, hypersensitivity, and hepatotoxicity were the most prevalent toxicity in our population. 70% of those toxicity were grade 3 and 4 and occurred mainly during induction and consolidation phase of therapy. Actually, majorities of these toxicity managed supportively without the permanent discontinuation of big asparaginase, except for pancreatitis, which lead to complete deletion of big asparaginase from treatment plan. So what about toxicity that associated with the dosing? Actually found the prevalence of hyperglycemia was significantly higher for patients who received 3,750 and higher compared to those who received less than 3,750. And no difference was found between a group regarding other toxicities. For the predictors of big asparaginase toxicity, actually conduct bivariate analysis, and we found statistically significant difference in age, body surface area, diagnosis, and big aspar dose. With multivariate analysis, we found high-risk ALL and T-cell ALL 2.5 and 2.8 more likely to develop toxicity than other diagnoses. And regarding the rate of toxicity in regard to the route of administration, we found that no significant difference in rate of toxicity between patients who receive IV versus IM, and this finding actually was similar to the previously published studies. In conclusion, the overall distribution of toxicities found in our paper are consistent with previously published studies, including hypersensitivity and anaphylaxis. And in order to minimizing treatment interruption and their impact on the cure rate, actually we develop preventative measures, include pre-medication before the infusion, and also desensitization protocol to those patients who develop anaphylactic reaction during the period, the international shortage period of Arena asparaginase. And alhamdulillah, we have 7 patients successfully rechallenged with big asparaginase with multiple doses. And at the end, the study will lay the ground to establishing local data regarding the prevalence of the most common big asparaginase related toxicities. Thank you.